Good morning, everybody, and welcome to Surgery Grand Rounds. There is no commercial support for today's program. Any financial relationships of planners and speakers with commercial interests have been mitigated. A link to the evaluation will be passed out and posted in the chat. If you are ABS certified and want NGHS to report your CME credits to the ABS, please fill out the evaluation and give us permission to do that. If you have a question for the presenter, please hold until the end of the talk. If you are attending virtually, you may enter your question into the Q&A section and we'll read it aloud. And now it is my pleasure to introduce our speaker for this morning. Dr. Patrick Sullivan is a professor of surgery at Emory University School of Medicine and chief of colorectal surgery for Emory Healthcare. He is a nationally recognized colorectal surgeon with a clinical and academic focus on rectal cancer, multidisciplinary cancer care, and value-based perioperative outcomes. Dr. Sullivan completed his general surgery training at Emory University and a fellowship in colon and rectal surgery at the Mayo Clinic. Since joining the Emory faculty in 2011, he has held multiple leadership roles, including lead of the rectal cancer disease team at Winship Cancer Institute, co-director of the National Accreditation Program for Rectal Cancer, multidisciplinary program, medical director of the Enhanced Recovery After Surgery program, and chair of the Cancer Committee for the American College of Surgeons Commission on Cancer at Winship. His clinical expertise spans advanced rectal cancer surgery, transitional minimally invasive surgery, and complex colorectal oncology with a multidisciplinary framework. Dr. Sullivan's research and quality improvement efforts focus on optimizing perioperative outcomes, enhancing patient value, and advancing evidence-based care for colon and rectal cancer. He has been an investigator on multiple national clinical trials, including NCI-sponsored rectal cancer studies, and has authored numerous peer-reviewed publications in colorectal surgery, surgical oncology, and perioperative care. A committed educator and mentor, he has played a central role in medical student, resident, and fellowship training at Emory, serving as site director for the Colorectal Fellowship and as a frequent invited speaker at national and regional meetings. Dr. Sullivan is deeply engaged in professional societies, serving on committees for the American Society of Colon and Rectal Surgeons, the Society of Surgical Oncology, and the American College of Surgeons, and is widely recognized for his leadership in quality, education, and multidisciplinary colorectal cancer care. And now Dr. Foxhall would like to take the stage and say a few words.
Thank you, Suzanne. I don't know what more I can add to such an illustrious career for a young man. We first met at Georgia Surgical Society, where he was the secretary, who is the workhorse of that organization, and that's who does all of the planning and year-to-year recruitment of speakers. And so you know he has limitless energy, as you can tell from his CV. The one thing I would like to say about Georgia Surgical Society is when you guys are out practicing in Georgia, I want you to think about joining this organization. It's an excellent education opportunity, but more importantly, it's where you make relationships with friends and colleagues and coaches, someone that you can call when you have a question or concern, and they are already in your speed dial and will answer you and know immediately who you are. So please keep that in mind when you're out. Look at the Georgia Surgical Society. But it is indeed my pleasure to welcome Dr. Patrick Sullivan. I'm looking forward to his talk on the current trends of and treatment of rectal cancer. And I would like to welcome to the podium my friend, Patrick Sullivan.
Well, thank you, everyone. Geez, I feel like Michael DeBakey up here with the gratitude that I have and the gracious host that you've all been. I think the underlying theme of this talk is going to be relationships and teams. Relationships and teams. No one can do this work on their own. And the Georgia Surgical was a opportunity for me to really meet people from my home state. This is yours, this is my state, our state. It's meaningful to me. And to meet Ed Foxhall and Pepper Brown, to go out last night and break bread with Drs. Royal and Fernando Esanina and Michael Cormican, who I worked with at Emory. It's meaningful to me. Really appreciate it. Well, I want to talk to you today about the last 6 inches of your GI tract, the rectum. Now, you may say rectum, it's not cardiothoracic, it's not plastic surgery, but for me, it's my passion. And you're talking an organ that's about that long, 6 inches long. But very similar to Manhattan, it is the real estate. The real estate there is pricey because if you have a problem or a recurrence, it can be a big problem. So I'm going to talk to you a little bit about how that has changed, how the management of this disease has changed. But first, I want to talk about Winship. I come from Emory Winship Cancer Institute. Who is Winship? Well, I think it's important to know the legacy of where you came from. Robert Winship Woodruff was the prior CEO of Coca-Cola. Coca-Cola and Emory have had a strong bond because Robert Woodruff, who was the previous CEO from 1923, really to his death in 1985, really expanded and popularized and made Coca-Cola a name brand in your homes. And in 1937, his mom came up with breast cancer and was treated at Emory and really had a great experience there. And Robert had a vision to make, to have a cancer institute in the city of Atlanta that would be second to none, and made a large contribution in 1937. And he has never had kids. Robert didn't have kids. And his legacy lives on because he has a philanthropic portion that he consistently is helping us with our initiatives. So there's a strong bond between Coca-Cola and Emory. And if I see any Pepsi products here, I'm going to be taking names. So I'm going to start with that relationship, the relationship between Emory and Coke. Similarly, I have no disclosures, but this is my home team. And I think about it as a team. We're all a group, everyone's contributing in. And when I look at this group, I think about taking care of rectal cancer. You have towards the screen right, my wife, she's medical oncology. You have radiation oncology, pathologist. The little dog, Riley, he's supportive oncology. Everyone likes him, he's helpful. But the brightest there you'll see is surgery. That's me on the left. That team effort, this is our team at Clifton campus. These are the colorectal surgeons. My best friend at work and the people, the person that I confide in, the person that hired me is Charlie Staley. I think he came up here to give grand rounds. He inspired me when I was young, when I was your age. And I can remember working with him thinking, man, I want to be like him. He could light up a room. His patience, he could meet someone in 5 minutes and have a tremendous, a relationship. He was able to harness some commitment and trust, and patience really hooked with him quickly. He had a knack for that. And he was skilled, and he had great judgment. And people would come up to Charlie and ask him questions about complex cases, and you would think that Charlie wasn't paying attention, but he was thinking 3-4 steps down the line. And I thought, man, I really want to be like this guy. So I worked with him. One of the best parts of training was when I got to work with him and do complex colorectal work, and he really flipped my switch. And I got interested in it. So I went on for training at Mayo Clinic, and then I came back. So this is the team at the Clifton campus, which would kind of be like your home base here. We have 4 of us. Ellen and Genevieve are my other colleagues that do colorectal work. And I recently became the division chief for colorectal. So I now am leading this group. These are my other colleagues that are across the other locations. We have 5 hospitals, about 2 at each location. And really, these are our kids. We are now 5. We're going to be into 6th fellow now. And these are the people that we train. So I feel a tremendous responsibility to make sure that these men and women come out well-trained and have a similar experience to what I had when I was a fellow, that Charlie Staley, who really inspired me to be better and to become a colorectal surgeon. Well, we're talking about the colon and rectum. The colon and rectum is a organ that's about as long as you are tall, about 5 feet long. And we're particularly interested in the rectum, which is 6 inches long. But you can see there on the sagittal imaging that it is important real estate around there. And we treat the rectum a little bit differently because recurrences in the rectum can have really deleterious effects. If you ever taken care of someone with locally advanced rectal cancer that is unresectable, it is a miserable existence. So we're talking about getting better at trying to help people with this disease. How important is it? How much of a deal is this? Well, I'm going to tell you a few things. Number one is that colorectal cancer incidence is increasing in young people, and I'm going to show you some data that's going to be a little bit eye-opening. 2 is that for locally advanced rectal cancer, that is cancer that has gone through the rectal wall or that has evidence of lymph nodes, that total neoadjuvant therapy, putting everything up front, improves outcomes. And those that have a complete clinical response, in other words, those that have had treatment and we don't see anything on MRI or on endoscopy, we can watch those patients safely. And then now, more than ever, patients whose pathology that we review, we need to look for mismatch repair deficiency. Because if you're mismatch repair deficient, you benefit from immunotherapy, and almost none of those patients need any further treatment. In other words, they're cured. And then now I think we can think about the selective use of radiation and hopefully avoid radiation in some patients who may not benefit from it, and we'll go over some of that. But again, the theme of the talk, teams, relationships. Patients come to us distraught. When they hear the diagnosis of cancer, they think it's a death sentence. They think chemotherapy, throwing up, radiation, and they come to us with different goals. Some, like me, I have 4 children. I want longevity. I want to be there for my family. Some may be in their 70s and they say, listen, I really don't want a stoma. I want a quality of life. Some don't want an operation. They're fearful. They don't want to go on a knife. They don't want an operation. Well, I think of myself like a coach. And when people come in, the first part I do is listen to them. What are you fearful about? What's your concern? And you got to listen. Similarly, I have a coach for running, and I'm a little bit unique. I'm a surgeon. I have limited time. I can only work out in the mornings. And I met my coach there on the right, Greg, when I was on the road. I was out in the neighborhood running, and I kept on seeing this guy. And I said, one day I just got in front of him, and I stopped him. And I said, I see you running a lot. I said, I too am a runner, and one of my goals is to run, I want to qualify for Boston. My first marathon, I had a 4-hour time about a decade ago, and Greg has been my coach. And sometimes he tells me things I don't want to hear. Right now we're training for March 7th is Albany, Georgia, and he'll track you. So, we share Strava, and he will know based on my track times and my times when I do my long runs whether or not I'm tracking for my goal. My goal now is a 3:05, but for Boston it was a 3:15. And he's worked with me. He knows the limitations of my schedule, and he's worked with me. And this past November I did qualify for Boston, so I'll be going. But Greg has been instrumental in that, and I think about that when I am coaching patients. What are their goals? What are they trying to accomplish? So in that, I want to share a story. And the story is Audrey. As I said to you, Emory and Coca-Cola have had a relationship. Audrey is a food scientist who works for Coke. She is a runner. She was training for a half marathon and began having bleeding. And as you can imagine, a 32-year-old coming in with bleeding, the first thing that the primary care doctor said it's hemorrhoids, and here's a little preparation H, and it was dismissed. She kept on having bleeding. Finally got a scope, and you can see where the lesion is there. The lesion, it was at about 12, 13 centimeters up, and she was devastated. So she came in with her husband. Her husband's an attorney. They've given me permission to share their story. And they had just got married a year ago, moved down here from Houston, and we're going to start a family. She had her dream job at Coca-Cola, and he's an attorney, started a practice. This devastated their world, and they wanted to start a family. So I want to use her case as we think about this disease. This is her pathology. As you can see, there's an adenocarcinoma. It's moderately differentiated. And as I said to you, we now look at mismatch repair status. These mismatch repair proteins are proteins that identify abnormalities in base match pairing. You remember T to A, C to G, and these proteins stop the machinery from replicating and say, we got a problem. When you lose those, you will develop carcinogenesis and propagate it. As you can see there, all of the 4 proteins were intact. Anytime you have a new diagnosis of a cancer, there are 3 things that go with it. You need to name it. What is it? Well, this is adenocarcinoma of the colon. 2, you need to stage it to see whether or not where the disease is and where they're spread. Number 3, treat it. So we're going to walk through that. This is her scan. We now stage these with MRI. We have a nice MRI facility, and now you get really crisp pictures. But you can see here, it'll go through again, that she's got a disease that's in the upper rectum, and it kind of straddles. You can see that common-shaped lesion right there. It straddles the rectal sigmoid. It's up about 12, 13 centimeters. And you can see here, too, that there are lymph nodes. They look like jelly beans that are along the blood vessels that are there. So she's got a T3, in other words, it's gone through the wall. In addition, there's evidence of lymph nodes here. So, we stage her as a locally advanced T3 N positive disease. So we're going to walk through where this is going. And how do we treat these? So this disease has gotten a little bit of notoriety. There's about 150,000 new cases of colon and rectal cancer. About a third of those are rectal, in other words, on the left side. It's now the #1 cancer-related killer in men less than 50. That's hot off the press this year. The #1 cancer-related killer in men less than 50. It's now surpassed prostate. It is now the #2 killer in women after breast in women less than 50. So we have a problem. Chadwick Boseman, known as the fictitious Black Panther in the Marvel movies, has really popularized or helped bring to light colon cancer. The lifetime risk for men is around 4%, a little less than women. But overall, it's increasing. This disease is increasing. We get data here locally, hometown of Georgia, our hometown, and we can see that the incidence is increasing in men and people less than 50. Not only that, but the mortality is increasing as well. So something's going on here. When you look at national data, not just Georgia, but national data, you can see that and for folks that are less than the age of 55, that the incidence is increasing. So the key concept is overall, the incidence of colon and rectal cancer is decreasing, but when you look in the subset of young people, it's going up, and it's concerning. This is national data, again, looking at, on the left, you have the quartiles of 0 to 49, 50 to 64, and then those over 65. And you can see that the incidence is increasing in young people nationally, as well as the mortality from the disease, stage for stage, is increasing. Why is that? Well, it's multifactorial. Mostly it's genetic, it's what you bring to the table, it's what you're born with. Sex, we know that men have a little bit increased incidence over women. But there is some exposure here that is causing this, and it seems to be mimicking the obesity epidemic. So there is some exposure that is related to the metabolic syndrome, chronic inflammation that is causing this increased incidence. Lifestyle, red meat, a World Health Organization, WHO, Class 1 carcinogen, red meat. The same class as cigarette smoking, asbestos, and plutonium. But we still propagate it. We still propagate the consumption of red meat, which I think is an issue. Antibiotic use. There's a group at Mayo Clinic, Heidi Nelson's looking at the use of antibiotics when you were a kid, respiratory illnesses, strep throat and so forth. When you got antibiotics as a kid, it wipes out your GI tract, your microbiota, and it seems to be putting people at risk. So there's a correlation between young kids, the amount of scripts that they got for antibiotics, and the potential risk later on for colon cancer. So there's some interplay there. Recently, there was a study done about 6 months ago. I have a meeting today about it, looking at chronic inflammation in runners. They looked at 100 runners, and they found that 15% of the runners, now these are endurance, you have to have had at least 5 marathons or 2 ultramarathons, but they found in that population of patients that the incidence of high-risk adenoma, precancerous lesions, was 15%. The general population is 1.2%. So it could be that there is some ischemia or inflammation that happens relative that is causing some change in the microbiota here. So in those that have locally advanced rectal cancer, like Audrey, this was the paradigm when I was growing up. Most patients, when they had locally advanced disease, they would start with chemotherapy radiation. Then we would operate to do the TME, that mesorectum that surrounds the rectum. Next, patients would go to chemotherapy. The issue, though, is that we became very good at local control, single digit. In other words, when we would operate on someone in this paradigm, the local recurrence rate was peanuts, 2, 3, 4%. But where we were losing patients was systemically, in the liver mainly. They would recur in the liver, and they had systemic disease, and that's where the problem was. So 2 things came out of this we wanted to improve. This was a standard for decades. But we began to think, can we get better at the systemic recurrence of this disease? And we found that there were some patients that when we do this, about 15% of the patients, when we remove their rectum, they didn't have anything in the specimen. So Angelita Habergama, São Paulo, Brazil, came out with this study over 2 decades ago. And she said, do we really need to take out the rectum in patients who don't have anything there? In other words, on either imaging or on endoscopic evaluation. Do we really need to take those out? She felt as though we didn't. And when she published her data and she presented at ASCRS, she was criticized harshly. She was compared to the Tuskegee trials, saying that you're experimenting on people, you should be taking out the rectums because they're going to recur and be a problem. She was ostracized. Well, her thought was, when we look at these patients with rectal cancer, do we need to take them out? When you look at the left side of the picture there, you can see a endoscopic picture, an ulcerated lesion. You could see the correlate on the MRI on the left side. And then when they get pre-treated with chemotherapy radiation, they do quite well. And there's really just a scar endoscopically, and there's really just a scar on the MRI. It's just a black scar. And she said, do we need to take these patients out? Let's study it. Well, she compared 2 cohorts of patients, 71 patients who had a complete clinical response. In other words, she can't prove that there's any disease. And then she compared those patients to 22 patients who had their rectums taken out, that had nothing there. The pathologist said, hey, listen, Angelita, there's nothing in this. Well, she compared those. And when you compare those, she had a 7% recurrence rate in those that had a complete clinical response without surgery, with 2 endoluminal recurrences, and 3 that had distant metastasis, versus 22 patients who had a surgery and had a complete clinical response. Most of those patients were coming out with a stoma. Most had there was a portion that had peristomal hernias, and there were still 3 patients with systemic recurrence. So although you took out the rectum, a complete pathologic response, there were some that were still having some metastasis. When you look at the 5-year overall survival as well as the 5-year disease-free survival, you can see the patients under watch and wait did pretty well. They had 100% 5-year overall survival and a DFS that was 92% compared to 83%. So this generated a lot of thought. One, can we do better? Can we increase the people who have a complete clinical response or pathologic response by increasing that number? Can we increase that number? And 2, do we need to operate on these patients? It really gave us a lot of thought. So Julio Garcia Aguilar did the timing study. And what he said was, if we start with chemotherapy radiation, we have to wait a little bit until we operate on them. So what he was doing was giving 2 weeks of chemotherapy as he's waiting for an operation, then it increased it to 4 weeks and then 6 weeks. And what they found was the more chemotherapy that you gave, or the longer you waited after radiation, the higher the rate of a pathologic complete response as a surrogate to overall survival. So chemotherapy and medical oncologists were like, God, maybe we could cure this cancer without surgery. And it was exciting. And this led to two larger studies looking at whether or not we could do TNT and how patients do. The first was the Protégé 22 trial. As I told you, the standard was up above the preoperative chemotherapy radiation, followed by surgery, followed by chemotherapy. Now, one of the key concepts is that when patients go through surgery, not all of them get chemotherapy. Not everyone has a great outcome. They may be struggling with infection or debilitation after surgery, and they may never see chemotherapy. Therefore, they may never get the benefit of it. So this trial looked at whether or not adding everything up front would improve really the disease recurrence that was in the liver. And what they found was that the complete pathologic response doubled. So from 12% to 27%, more than doubled. In addition, the disease-free survival improved by about 7%. And all of that improvement was in the liver. So they were able to do what they wanted to. They were achieving a better durable response in the liver, leading to improved overall survival. This was replicated in the Rapido trial, looking at really the bad tumors, bulky T4 lesions, big bulky lymph nodes, threatened margins, and they use short course radiation here, but also chemotherapy up front. And again, almost a mirror image of the Protégé 23, that if you put everything up front, it improves the complete pathologic response, as well as it improves the recurrence in the liver. So two trials that we hadn't had any data on in about 2 decades has now changed it to everything up front. Now, what should we do first? Should we do chemotherapy first, or should we do radiation first if we're going to do a TNT approach for locally advanced rectal cancer? And that's what the trial here done by Jose Aguilar was trying to ask. What should we do first? And what they found was that if you start with radiation first, in general, for patients with locally advanced rectal cancer, there's an improvement in your ability to have organ preservation. That the patients who start with long course radiation first have a better chance of preserving their rectum and anus. In other words, not needing surgery. And it probably is related to the timing. Radiation is a gift that keeps giving. As you wait for radiation, as you separate yourself from the initiation of radiation, patients continue to have benefit from it. So therefore, they showed that the 3-year organ preservation rate is higher if you start with radiation followed by consolidation chemotherapy. So the organ preservation rate, more than 50%. In addition, they showed that if you do recur, that it is manageable, and it's manageable well, but you have to stay on top of them. Now this is in the NCCN. You can manage patients, for those that have a complete clinical response, that it's reasonable to do a watch and wait approach and watch them. But it takes an effort. You can imagine that If you're going to do watch and wait, in my opinion, the onus is on us to be able to keep an eye on those patients, because we know about a third, 25 to a third are going to recur. And if they recur and are no longer resectable, I think that we've done them a disservice. So we at Emory have a colorectal cancer coordinator that owns this. That when we say, listen, Monica, this is a complete response, we discuss them at MDC, she owns it. She has a spreadsheet with a tickle file that's every 4 months or every 3 months, she's calling them and scheduling and making sure that we're staying on top of these patients. And we just have published our data on over 100 patients on our watch and wait program, and about 28% had recurrence. Most of those were able to be re-resected and did quite well. But what we found was that initially patients are excited about it. In other words, it's pretty intense. Every 3 months you're coming in for something, either a flexible sigmoidoscope, an imaging study, CEA, or an H&P. And what happens is they get fatigued. So early they do well, and then they fatigue. And so Monica staying on top of them has really been helpful. The other key concept is that if you recur, almost 85%, the majority of them will recur within 2 years. So the intensity of the surveillance has got to be tight the first 2 years, because you want to capture most of them. Now let's get back to Audrey. Audrey, is this truly rectal cancer? I think some could argue that this is a more proximal lesion and may be able to be treated like a sigmoid, and we'll go over that. But more importantly, Audrey wants a family. She wants to start a family. She just got married. So how does that treatment affect her? Well, pelvic radiation will, if you radiate the ovaries, you're not going to be able to ovulate, you're not going to have children. So that's a big deal for Audrey. What about chemotherapy? Well, at least in the short term it does. Chemotherapy but there are a percentage of patients, 10 to 15%, that after getting chemotherapy won't be able to ovulate and have children. Surgery can affect fertility, because when you're operating in the pelvis, you can cause scar tissue to around the ovaries as well as the fallopian tubes and decrease the risk of being able to have children. So these are all factors that are important in making a decision for Audrey. So first is, should we do upfront surgery for Audrey? Well, when you look at the upper rectum, really the upper rectum is similar to the colon. That when you look at the ability for you to get a circumferential radial margin as well as the lymph nodes and come out with those technical features, the upper rectum probably behaves similarly to the rest of the colon in terms of your ability. As you get further closer to the anus, your ability to get negative margins becomes a little bit more difficult. And the number one predictor of local recurrence in the rectum, the number one predictor is a positive circumferential radial margin, defined as less than 1 millimeter of tissue. So if you have a tissue that's less than 1 millimeter from the margin, it's positive, and your recurrence, pencil them in. You're going to see them back with a recurrence. So the picture on the right there is just showing that fat. I think about the rectum like a hot dog in a hot dog bun. I want as much of that bun around it to make sure I get a radial margin on that hot dog to make sure that I get a negative margin. So in thinking about it, Audrey had some lymph nodes but no real threatened margin. So this is a reasonable approach. And you can see here from the Dutch TME trial that the upper rectum that is greater than 10 centimeters above the anal verge had similar outcomes to colon. So it's a reasonable approach. However, for Audrey, she said, if I do a TNT approach, I want to avoid potential radiation. How do we do if we avoid radiation? Well, this was Deb Schrag's work while she was at Memorial Sloan Kettering, and she designed the Prospect trial, which asked, do we need to radiate patients? And are we gonna, can we just use chemotherapy to mop up any microstatic or micrometastatic disease and have those patients go for surgery? In other words, can we be selective with the use of radiation to avoid all the complications that I just talked about with radiation? Well, we know that the long-term toxicity from chemoradiation is clear. There's impaired bowel, bladder, sexual dysfunction, sometimes impotence. There's increased risk of pelvic fracture and secondary malignancy. There's impaired marrow reserve. There's infertility and premature menopause, increasing the diagnosis of rectal cancer before the age of 50. So the advances in chemotherapy, imaging, screening have improved. And the premise of the hypothesis is, can we selectively use radiation? And this is the study scheme. So compared to the old reliable, which was the upfront chemotherapy, radiation, followed by surgery, followed by chemotherapy, these investigators said, can we start with chemotherapy first? When you use FOLFOX is a doublet. It includes 5-FU as well as oxaliplatinum. And with that, if you responded well and your tumor shrunk, at least by 20%, then you can go right to surgery. If it didn't shrink, in other words, if we gave you chemotherapy and the disease did not shrink, then you would go to the standard, which is the radiation. So the scheme, it was very intriguing, because the scheme, if chemotherapy is effective, this could be a game changer. The inclusion criteria was locally advanced rectal cancer in patients that you could do a resection on, that you could remove. They weren't on really bulky T4 disease, and they weren't in patients that would eventually need an APR. The surgeon had to say, I can take this out. And that was the exclusion criteria. So the endpoint was disease-free survival. They looked at other endpoints, like your ability to get a R0 resection, because I just told you the most important predictor of local recurrence is a negative circumferential radial margin. So if you're doing chemotherapy that may not shrink it, and you're taking patients to the operating room and you're coming out with a positive margin, you've done them a disservice. So they looked at overall survival, R0 resection, and as you can see, 550 patients per side. This is a big trial. And if you look at them, they're pretty well matched. Age, sex, and the distribution of the rectal cancer staging. And if you look at it, the disease-free survival, those two lines are intimately involved with one another. Pretty similar outcomes. In addition, the local recurrence rate, look at that, single digit, 1.5%, single digit local recurrence. So chemotherapy and surgery was pretty effective. As you can see here, this is 90% overall survival, and both quite good. The surgical endpoints, how often did patients have a complete pathologic response? I told you earlier that the chemotherapy radiation group, about 15% had a complete clinical response. Here, with just upfront chemotherapy, you're looking at a complete response of 22%. So pretty comparable to radiation. How many patients needed to go on for chemotherapy and then radiation because they didn't have that response? Very, very few, only 9% of patients. So it seems as though this is it's not inferior to the chemotherapy radiation that is traditional, and some patients may be able to benefit from this. And it is now part of the NCCN. You can see there in the lower part that if you can choose to start with upfront chemotherapy, and if you have a good response, go right to surgery and avoid the deleterious effects of radiation. So, upfront chemotherapy with the selective use of radiation is an option for patients. So the plot twists a little bit here with Audrey. Audrey's cancer, I told you initially, was a mismatch repair proficient. In other words, she had all the proteins to be able to identify her as a sporadic cancer. However, when they did they did more molecular testing on her, NGS, and they found that Audrey had a loss in her PMS2. So Audrey has Lynch syndrome. Lynch syndrome, in general, has a loss of mismatch repair proteins. It's pretty uncommon to have a Lynch syndrome patient have a sporadic cancer like Audrey. So her bone marrow, in other words, her congenital bone marrow has Lynch syndrome. She has loss of heterozygosity. However, this particular cancer that Audrey has is a sporadic cancer. Very, very rare. Well, let's say that she did have mismatch repair deficient rectal cancer. How would that change things? 2018, these two gentlemen got the Nobel Peace Prize for their use in immunotherapy. And what they hypothesized, James Allison, UC Berkeley, my brother lives in Berkeley. I went to visit him with the last American College of Surgeons. I went to visit him, and we were on the campus of Berkeley, and he took me to James Allison's lab. So I got to see where James did these studies. But the hypothesis was that you can use your own immune system to recognize protein and to be able to kill cancer. So it turns out that when a antigen-presenting cell comes up to a T cell, there is an abnormal protein that your T cell will recognize. But in order to take that cell out, you need co-stimulation. And that co-stimulation are these proteins here, the CTLA4 as well as the PD-1. And what happens is, if you lock into that, it inhibits the T cell from being fired up. If you inhibit the inhibitor, it cranks the T cell up to say, this is not self, and I'm going to take this cell out. It's like putting gasoline on a fire. So your immune system now becomes tuned up and is no longer inhibited and starts to kill the cancer. The issue, though, is that this has not been effective with sporadic colon cancers. Why? The reason being is because sporadic colon cancer is pretty programmatic. You start with an APC mutation, and then you start to walk down KRAS, DCC, and you end up with P53. It's pretty programmatic. That's what Vogelstein did. He was able, that's why from normal mucosa to an adenoma, it takes 5 to 10 years. From an adenoma to cancer, another 5 to 10 years. That's why the colonoscopy without any family history is 10 years, because of what Vogelstein did. However, when you look at the cell surface of a typical colon cancer or sporadic colon cancer, there's very little antigen on the cell surface. Very little antigen on the cell surface. However, with mismatch repair deficient cancers, there's a ton of debris on the surface because it doesn't go through the regular sporadic proportions. So these guys were onto something. And when you look at the milieu of mismatch repair deficient colon cancers, which are about 15% of all colon and rectal cancers, and about 6 to 8% of rectal cancers, you can see that the milieu on the bottom left, there's a lot of immunogenic cells there. There's a lot of T cells. It's similar to Manhattan. These cells have a lot of cell surface, a lot of signals, a lot of antennas on their surface. Versus out in Wyoming, sporadic cancer, there's very few antennas. The landscape is bare. So when you see a lot of antigen in the cell surface, your immune system can crank it up and kill these cells. At the same time, Andrea Surchek was doing research on this, and she found that, you know, the majority of patients with sporadic colon cancer, they do quite well with chemotherapy. However, there are these patients that don't do well. And in this study, she found that 30% of these patients didn't respond to chemotherapy. So she said, why don't we try something else? These patients aren't responding typically. Something's different about their biology. So she began to say, let's take these patients who don't respond to the chemotherapy and let's try immunotherapy on them. And here you can see the scheme. Dostarlimab is a PD-1 inhibitor. I just told you that you're inhibiting the inhibitor. You're putting gasoline on the immune system, and the immune system is tuned up looking for these antennas. And what she found was that patients who came in with mismatch repair deficient and with this scheme did quite well. You can see here on the left, the baseline, that's a pissed off cancer. You can see it's ulcerated, it's thickened, it is almost occluding the lumen, and with just 3 months of immunotherapy, it's taken every 3 weeks, pretty well tolerated, very well tolerated. It's a pill. You don't have to come in for infusion. You don't have to go on gantry for radiation. Look at the response rates. Very rare to publish in the New England Journal of Medicine based on 12 patients. This hit the front page of the New York Times. My phone was ringing off the hook because patients were saying that rectal cancer was cured. Yeah, this is outstanding. However, it's only about 8%, 6 to 8% of all rectal cancers. However, if you do have mismatch repair deficiency, it's a game changer. Those patients don't need chemotherapy, no radiation, no surgery. Andrea Surchek just updated her experience just this past June, 6 months ago. And the key concept here is that mismatch repair deficient cancers are site agnostic. Doesn't matter where it came from. It could be colon, it could be gastric, it could be GE, it could be HPV, it could be urothelial. They all do well with immunotherapy. So now, any solid organ at Emory, we test them all for mismatch repair status because it's a game changer. If you identify these patients, you can avoid a lot of harm. So getting back to this, turns out that she started with chemotherapy, and she had some response. But in that NGS that I talked about, she had HER2 neu overexpression. And HER2 neu, similar to breast, is a target. And we were able to target her with HER2 neu, trastuzumab and tacitinib. And she really had a nice response with the HER2 neu overexpression, which we treated her with. And she ended up going for robotic resection. And this is after she was post-op at 2 weeks. And so we resected her. She had downstaging with a T3N1 disease. And Audrey now is doing quite well. She's looking forward to getting pregnant, starting her family. She's now out almost 2 years now from her surgery. But it was just a great case to be able to bring to life some of the key concepts of how this disease has evolved. Future directions, adding more. You know, do you ever see that skit from Saturday Night Live with the cowbell? More cowbell, you know, more chemotherapy. So we're adding a triplet now, more chemo. So we've got FOLFOX, irinotecan, and oxaliplatinum. The trial just closed. It's the Janus trial, and we're waiting for those results. In other words, if we do more TNT, more chemotherapy, we might be able to get a little bit more bang out of the buck. We're starting a trial at Emory. We're just starting to open it up for HER2 neu overexpression. And these are about 6 to 8%. Mainly, the HER2 neu overexpression is left-sided colorectal cancer. So we are now screening everyone for HER2 neu, and we are starting them on we're starting them on therapy for decreasing HER2 neu. And so far, the patients who have been on it have been are getting great responses. So the key concept is that this is no longer a heterogeneous group. This is no longer a homogeneous group. We're finding that there are molecular signatures to this disease that we are targeting. So we're about a decade behind breast cancer, I think. As we get more savvy, more disciplined, understand differences, understand biology, we're going to be chipping away at this disease, and we're going to get better. And then next is looking at mutational burden. I told you that mismatch repair deficient cancers have a lot of antennas on the cell surface. And what we're finding is that when you radiate a cancer, you initiate a lot of cells that are in the milieu of that. So what we hypothesize is, let's radiate them and then give immunotherapy. See if we can't turn on the light switch and have the cells that are there start to help us. So that's another avenue that we're looking at starting. The Janus trial, this is the trial that I talked about, looking at adding a triplet to the TNT approach. And so far, I think you'll get a little bit more squeeze, but it's not going to be a deal. You know, it's not going to be as beneficial as the immunotherapy was. But hopefully, it'll chip away at the numbers. So, my approach to managing locally advanced rectal cancer. I'm talking about a subset, which is the T3N positive disease. Key concept, you have to test mismatch repair. So whenever your team or your juniors say, hey, this patient's got a new rectal cancer, it's an adenocarcinoma, you stop them and say, what is the mismatch repair status? Because it's a game changer. We've had several at Emory, hurtful, that have come with colon or with rectal who hadn't had it checked, who got chemotherapy radiation, who were referred to us for surgery. And we started with the basics. When they came in, we picked up 4 or 5 patients who have missed the mismatch repair status because it's not standard. We treated them with immunotherapy, and they didn't need anything more. Game changer. So you got to check that. If it's distal, we do TNT to try to avoid, to try to do organ preservation. If it's mid or upper, you can use this. You can use TNT, or you can do chemotherapy and go right to surgery. If the patient has a shorter life expectancy, comes in with oxygen, wheelchair, or a walker, then the goals change a little bit. You're not going to be operating on that person. You're going to see what you can do to avoid it. So you're a coach. You're a shepherd. You are a chaperone of these patients coming in, and it's important that you're armed to take care of them. Getting back to Angelita, she is now revered. This is her every year we have a rectal group that meets in New York, and I befriended her, and we've done research together now. And she has changed the scape of the way we treat and think about rectal cancer. She was ostracized in the beginning, and now she is beloved. And it took a risk. It took a risk. She took a risk, and she's helped a tremendous amount of people. So I told you what I was going to tell you, and I'll tell you again. Colorectal cancer is increasing in young people. TNT is now the standard for locally advanced rectal cancer. If patients have a complete response, you can watch them. Don't miss the mismatch repair deficient cancers. And young people can selectively avoid the use of radiation. Thank you. Happy to take any questions or concerns.
Thank you, Dr. Sullivan. If you're watching online, I'll remind you, if you have a question, please put it into the Q&A chat and we'll ask for you. And we have a question in the room.
Thank you for the excellent overview. I have a couple questions, actually, if that's okay. But the first one is regarding metastatic rectal cancer with limited or oligometastatic disease, for example, in the liver. We know that a subset of patients with metastatic colorectal cancer can be cured with combined liver-directed therapy and treatment to the primary tumor, along with systemic therapy, obviously. But the question I have is about a watchful waiting approach in those patients who have a rectal cancer with limited liver disease. I know the trials excluded metastatic patients. What are your thoughts on future directions where, if we're able to clear the liver along with optimizing systemic therapy and chemo, it's not really total neoadjuvant, but a quote-unquote total neoadjuvant to the rectum, can these patients also be included in a watchful waiting approach, or are all of these patients always going to need surgical resection of their primary site if we're able to otherwise clear the metastatic sites?
Yeah, great question, great question. So to reiterate, this is, he's asking about legal metastatic rectal cancer, that you've treated the metastatic disease in the liver, but down in the rectum, if they've had a great response, can you watch and wait on those patients? That is that's a really debated topic in our MDCs. Personally, I choose to watch. I choose to watch. By far the majority of patients at Emory, and I would say across the nation, who are in centers that have the ability to do it, we watch. Why? Because we know that this is a slower growing disease, and it's very uncommon that you're going to lose someone in a 3-month window. So there are plenty of patients, as you described, that have treated disease in their liver that we watch, the rectum. For me, you got to prove to me that I need to be in your rectum and removing it. If you've ever taken care of someone with low anterior resection syndrome, or that their life is now affected by it, they can't go to the grocery store, can't go to Costco, have to always be by a bathroom. It's devastating. And there's nothing, for me, that's more devastating that when you put someone through risk and they have a complication and there's nothing in the specimen and you see them suffering. I hate that. So yeah, I watch those patients. I don't operate on them, but we watch them. Now, if they have regrowth without anything in the liver, then we'll go after them. But I have several patients on our watch and wait that are like that have had treated rectal metastasis to the liver, either directed or resected, and that we watch the rectum. So the key concept, you have to prove to me that something's there before I go.
And then my other question, so, as a surgical oncologist, I can't help but draw a comparison between a lot of things that have happened over time with rectal cancer treatment and esophageal and GE junction cancer treatment. They're opposite ends of the GI tract, but very similar kind of treatment paradigms, and we've seen similar shifts. Recent trials have now changed the standard of care from chemoradiation to perioperative chemotherapy, and there's even some places now looking at almost a total neoadjuvant therapy type of picture. However, there's been no trials up to date that have done a watchful waiting. The one trial that was recently published in 2025, because the newer data hadn't come out yet, was using chemoradiation, not total neoadjuvant therapy. So, and one of the biggest concerns with watchful waiting in esophageal cancer is that can we be certain, based on endoscopy and imaging alone, that there's not microscopic disease submucosally located? And I was wondering if you can speak to that and those concerns, because I'm sure many of those concerns early on were also present as total neoadjuvant therapy was being attempted in rectal cancer.
Great points. In my opinion, breast cancer led the way. We're a decade behind breast cancer with our thought process. You guys are another 5 to 10 years behind rectal, GE junction. But I bet you that you're going to come to the same conclusions. So we had the same fear. But what we found was that regrowth almost always is endoluminal. It's not like you're going to have some cells in the middle of the wall of the rectum that you're not going to see. Very, very rare. Almost always the recurrence is endoluminal. So I think that what you'll find, those trials are coming. In fact, with GE junction, what he's talking about, adenocarcinoma GE junction, is similar to rectal. They have a complete pathologic response rate of about 12%. So they're taking out esophaguses, bringing up the stomach, huge operations, and sometimes they run into patients who have a complete pathologic response.
With the recent addition of immune therapy to the peri-op regimen, it's even gone up, I think.
Yeah. So I bet you're going to be seeing trials that they're cooking. They're cooking that we're going to it's going to be similar. In other words, you have to prove, because they're so big, the surgeries are big life-changing events, that you need to prove that there is actually disease there before you resect it. So I think that it's going to happen, and I think that with the advent of MRI, with good imaging, now we're doing MRI PETs that are even more helpful. Diffusion-weighted imaging, so you can see the milieu of a cancer. Cancers in general have a lot of water in them, so they restrict diffusion. So they're bright on T2 imaging, on the restricted diffusion. But when you treat them, they become a scar. Less water, dark. And I think that with that, endoscopically, ultrasound, MRI, you're going to find that you're going to be a lot more selective. And you're going to be watching these patients where you won't lose them. If they do have a regrowth, you're going to be all over it, and hopefully you will not disturb a overall survival once they recur. A similar experience to us. When we recognize a recurrence or see a recurrence, we're able to resect it and have a good outcome.
Thank you so much.
All right. Any other questions or comments in the room? I don't think we have any online. Oh, yes, hold on.
So rectal cancer. I never thought I'd be up as a proctologist or a rectal cancer when I was younger, but I just had a passion for it. I really enjoyed it. I enjoyed it's a difficult disease, and I really enjoyed taking care of patients with it. So I hope to inspire you guys. Find your passion. What do you really like when you're in clinic?
Yes, sir. I had a quick question just in regards, what would be your advice to, let's say, the general surgeon or acute care surgeon? You have a patient that comes in severely obstructed. You do suspect this. Let's say they're not perforated, but they may need an operation to bypass or divert away. Do you recommend that, or do you recommend upfront just getting that patient to like a colorectal cancer center, such as yourself, to evaluate, or do they lose any, value in the upfront operation to bypass to provide them relief of obstruction before they perforate and stabilize, then get to you for potential treatment down the road?
Yeah, I appreciate that. I think it's dependent upon your skill set. I never subscribe to we do it better. I don't believe that. There are some outstanding general surgeons in practice that do a fantastic job and that smoke the colorectal decision-making. So I just told you the key concept. The key concept is if you come out with a positive margin, pencil the patient in for a recurrence, right? So the key concept being if you can't, in general, those that come in obstructed, more than likely you're going to be coming out with a positive margin. So you have to either stent, if you're coming in with a plumbing problem, you got to open up the blockage. So you either have to stent them or proximally divert them. Very rarely do we go after those initially because of what I just told you. There's no question that those that have an obstructed cancer are at high risk. That's what the FASCRS trial, the Neo trial has shown us, that if you give those patients upfront chemotherapy, you shrink them and you're much better ability to be able to resect them to negative margins. So yeah, you either got to stent them or divert them and then go after the disease after they've gotten some treatment for the key concept of getting negative margins. So almost never do we go after those initially. We always pre-treat those.